Are we good to go now?
Yes.
Okay. Good afternoon or good morning to everyone, depending upon where you are joining us from. And thank you so much for being a part of this webinar. My name is Helen Stone, and I serve as the District 1 Commissioner for Chatham County. I also have the honor of serving as the chair of NACo's Health Policy Steering Committee this year. And in this role, I am committed to leading us towards progress on important issues, such as the one that we're going to discuss today. For years, the NACo membership body, in partnership with organizations such as the National Association of County Behavioral Health and Development Disabilities Directors and the National Sheriff's Association, have been advocating for the amendment of a policy known as the Medicaid Inmate Exclusion. This unconstitutional policy unfairly removes access to federal health benefits such as Medicaid, Medicare, Children's Health Insurance Plan, or CHIP, and juveniles upon entry into jail, regardless of whether or not they've been convicted of a crime. As you all may know, county jails are the entry point into the criminal justice system, and counties invest nearly $200 billion a year in community health systems and justice public safety services. There are more than 10.6 million individuals who are admitted into the 2,785 county-operated jails every year. Counties are required by federal law to provide adequate health care for these individuals by the statute of the 8th Amendment of the U.S. Constitution. The Medicaid inmate exclusion's biggest failure is that it makes no distinction between a jail and a prison. National data estimates that an average daily population of a jail is split nearly half and half between pretrial detainees and adjudicated individuals. Across America, the double standard created by the Medicaid Inmate Exclusion Policy, or the MIEP, is putting undue hardship in our local judicial, law enforcement, public safety, and human services systems. This error in legislation and federal policy results in higher rates of recidivism, increased healthcare costs, and poor health outcomes for Americans. This policy drives the over-incarceration of those suffering from mental illness and substance abuse disorders, as county jails have become the largest behavioral health facilities in the nation. But through our long-term advocacy work, we have opened up new pathways for us to address this issue through new and impending legislation in Congress. For today's webinar, we will be joined by experts who will remind us just how important this policy is, while providing insights on new ways we can collectively work as a membership body to make advancements on this issue in Congress right now. One of the biggest opportunities we have is through congressional work on policies that will address the nation's growing mental health crisis. Here to talk more about this work and provide insights on the timing of what we hope to be a transformative package of bills for mental health is our first speaker, Mr. Rodney Whitlock. Mr. Whitlock is the Vice President of McDermott Plus Consulting. He is an accomplished healthcare advisor with more than 2 decades on the Hill, where he specialized in rural health, the healthcare safety net, and disability policy, with over 25 years of experience. Rodney, thank
you. Well, thank you all for having me. It is a pleasure to be here with you all. Certainly, those of you in the Georgia and the Carolinas, be careful out there. Helen, I know you guys aren't far from it, so we'll keep you on our thoughts.
Looking out at the river right now.
All right, so what I'll do is I'll give you a little bit of a thought on what to see coming up in, for the balance of the year and where the opportunities are, and what to talk about as we're looking forward to this. This afternoon, in probably a couple of hours, the House of Representatives will finish action on the continuing resolution to fund our government. It has been 25 years since the government was funded on time. We'll go for a 26th next year. And so we're going to have a short-term funding. What that means is that decisions on many, many policy areas have been kicked from right now until after the election. The election will occur on November the 8th. We'll know results to November the 9th, 12th, 24th, good knows. But we hope we know what's going on. That will then begin what we call the lame duck session. That's between the election and the start of the next Congress, where you have people who are there, but they're only there for a little while because they're not going to be anymore because they retired or lost or whatever. And so during that period, there's going to be an opportunity for a lot of policy to be considered. I'll start with this. The way the calendar falls this year, there's only 1 week for Congress to be in between the election and Thanksgiving. That is typically going to be used as an organizing week. We wouldn't expect a lot of activity then. They're going to figure out who's going to be on what committee, who's going to be leading the place, things like that. After that, they're going to go home for a week for Thanksgiving. They'll come back, checking my little calendar here, around November 28th, 29th for 3 to 4 weeks. I'm, in Washington, you guys are in America. What I can tell you is that in DC, we work right up against deadlines all the time. And so we're going to go right up to the shadow of Christmas, maybe further before we finish out this year, most likely. What we'll be working on then will be final funding issues for different areas of the government, including ones that affect us in health and human services, housing, etc. But then there'll be opportunities for other policy areas to be considered. We're going to be watching for work to be done on the mental health and substance use space. All of the committees have done work that tee them up to be able to talk about those during that lame duck period post-Thanksgiving. And then we also see possibilities for others related to the FDA, and then things that have been talked about throughout the last 2 years and could be on the table. Certainly the one we're talking about today is one of those where, as we move closer and closer to what we call in DC an omnibus, which is a big bill with a lot of pages. The one 2 years ago in the omnibus that passed in very late 2020 topped out at 5,600 pages. No, none of us read it. Of course not. I can't believe you even asked me that. Here, I saved you that now having to ask. But it's an opportunity for a lot of things to be considered. And so that's what we'll be watching for in that window, which then pushes me towards raising the subject of advocacy and pointing out to you, in the period of time between now and roughly Thanksgiving, if you see your federal policymakers out there working around campaigning, remind them of this issue, try to raise it in their minds, because this will be your window to get them thinking about it, because this is going to be the opportunity. I'm not saying it's going to happen. Lame ducks are like magic hats. You can see a lot of stuff come in and it's not always the rabbit that comes out. So we don't know exactly what's going to turn out, but that's the window for things to occur. Otherwise, we're back into the regular order of 2023. So Helen, Blair, others, is that a good enough of a warm up for you as to what you wanted this morning? Anything I can add or any questions you want to direct me towards?
Commissioner Stone, you're on mute, so you have to unmute.
Rodney, that was wonderful. I don't have any questions. Does anyone have any questions, Blair? Or you want to save those till the end, is that correct?
Yes.
Okay. Right. But Rodney, thank you for your presentation. You're going to stick around for the Q&A portion.
Yep.
All right. Okay, and so we're moving on, and our next speaker is Mr. Rene Hurtado. I'm sorry if I messed that up.
No worry, it's Hurtado. You're good. It's great. No problem.
How is it pronounced?
Hurtado, Hurtado.
Okay. All right. Well, here we go. The floor is yours, and you have been working with the Emergence Healthcare Network that provides trauma-informed care centered around the needs of individuals with intellectual or developmental disabilities. as well as behavioral health or substance abuse treatment needs. Your network offers a wide variety of programs at multiple locations throughout the area and has several mental health programs to assist individuals involved in the judicial system, starting from when a person is booked into the county detention facility to when they are placed on probation or parole. So thank you so much for being here today, and the floor is yours.
Thank you so much for the introduction. Thank you for the conference organizers today for giving us the opportunity. So yes, my name is Rene Hurtado, Chief of Staff for Emergence Health Network, the local mental health authority in El Paso, Texas. What I want to do today is share with you some national data that really shows the depth and breadth of the problem, and then do a little bit of a community perspective on what is going on in our part of the world, which hopefully kind of is reflective of what's going on in communities across the nation. So a little bit about Emergence before I get into the statistics here. As I mentioned, El Paso is in far west Texas, and we're the largest international community in the world. We have about just under 1 million people in El Paso and about 1.5 million in our sister city, Ciudad Juarez, right across the Mexican border here. Our particular location gives us some unique challenges in regards to providing community mental health, but I think it also provides a mirror to what's going on, as I said, in other parts of the country. We are the largest mental health provider in the region, and we offer a variety of programs for, as you can see there, children, veterans, the homeless population, persons in crisis, and of course, the justice-involved patient. We work with our government partners, our partners in education, business, healthcare to provide the best system of care possible. And in about the past 10 years or so, I'm going to say we have really focused our efforts on the justice-involved patient and really kind of creating a system where we have intercept points or points of contact throughout the entire continuum of care. Next slide, please, if you wouldn't mind. We're gonna get into some of the national statistics here, but as I said, we have worked with our partners in regards to doing some pre-arrest programming, such as our crisis intervention teams. We are very much involved in jail service. We are the provider of jail services in the county and offer a variety of services there. And then, of course, post-release, working on specialized programs for folks on probation or parole. So I think it gives us a little bit of a unique perspective there on what is the state of care for the justice-involved patient. But what I want to do today is again go into the impact that the justice-involved patient has on community mental health centers like Emergence. And let's begin with just the sheer numbers. So you can see here, 27, this is the 2019, these are the latest numbers that we have really from a national perspective. This is a study released in 2019. 27% of all jail inmates experience serious psychological distress. 14% of prisoners experience serious psychological distress, and 43% of jail inmates have a history of mental health issues. 37% of prisoners have a history of mental health problems. So 63% of all individuals sentenced to jail in state or federal prisons meet the criteria for drug independence or abuse, and then 58% of all state and federal prisons meet the criteria for drug independence abuse. So you can see there's by far a very large prevalence of mental health and substance abuse issues in the jail population. Next slide, please. This is a kind of a graphic representation of those numbers that I gave you, but I wanted to take this opportunity to just say that the burden of providing that care that is constitutionally required is not just by clinical providers. It is also shouldered by law enforcement and the judiciaries. And I think you will hear that from some of our upcoming panelists as well. And the solutions that we have been able to implement that do make specific, have made very specific impacts have happened because there is this type of very intense relationship between the clinician, the peace officer, and the judge. And I'm talking, of course, programs like CIT, like outpatient competency restoration, and of course, being the provider of services in jail facilities. Next slide, please. So I'm going to get into kind of the local numbers that hope will shed some light here. So the County of El Paso operates 2 jail facilities. We are the service providers for both of those facilities. We provide 24/7, 365 care at the jails. Last year, we saw 16,300 individuals in those kind of jail facilities, the most that are seen by any of our program by far. So that is where we have the most patient traffic. Every single individual that goes into the jail is screened for a historical needs assessment, and of course their current need. We have 30 individuals that provide care and support for this program: psychiatrists, therapists, caseworkers, all the way down to medical records clerks and office coordinators. Of those 16,300 individuals, 65% needed follow-up care. So in addition to the screenings, they went in and we set up clinical care, clinical programming for them for their time in the facility. And 25 to 30% fall under the priority population diagnosis, meaning that they have serious and persistent mental illness, meaning they have bipolar disorder, serious depression, and other type of serious mental health issues. So very diagnosable type of conditions there. Again, 25 to 30%. This cost the County of El Paso $2.5 million. And for a city that is of low socioeconomic impact here, like El Paso, right on the border, that is a significant burden that has to be shouldered by local taxpayers. Next slide, please. So from there, I'm going to kind of switch over to the children's side of services here. So we are not the main provider of children's services like we are on the adult side. And as you all know, providing comprehensive children's services is a much more complex undertaking, usually working with schools, working with oftentimes foster care systems, etc. So we are merely a cog in that wheel. But again, the lion's share of the expenses to provide care to at-risk children and their families is again shouldered by the local taxpayer. So we've got some national numbers here that I'd like to share with you. So again, 65 to 70% of all the 200 million children who are arrested every year have a diagnosable mental health disorder. 1 in 4 of those individuals, of those young adults and children who are arrested, have a mental illness that is so severe that it impairs their ability to function. Meaning we have truancy, we have dropouts, we have out-of-home placement. And then, of course, 2/3 of the individuals have a dual diagnosis of a mental health disorder and substance abuse. So again, a large burden of care that is often placed on local communities. As I mentioned, we are a minor player in the local system, but I do want to share with you kind of a little bit of a case study in regards to what we are doing and how community mental health centers are working with juvenile probation, juvenile justice organizations in their communities. Next slide, please. So Emergency Health Network offers multi-systemic therapy. And we work with, for those of you who are not familiar with it, it's an evidence-based wraparound program that provides very comprehensive care to at-risk youth in facing incarceration or out-of-home placement. It is an evidence-based program that has really exciting results. On the bottom of the slide, you can see there what we're experiencing in El Paso. Of those individuals that are involved in our MST program, 87% of them end up living at home, 88% of them are either in work and school, and 91% of them have had no arrests since entering into the program. So again, fantastic results. The program, however, is expensive. It is a program that requires very small caseloads by social workers. It requires non-traditional services that are not an easy fit for a Medicaid population or a managed care population. So what do communities do? They foot the bill themselves. So this is an opportunity to look for some innovation in financing and find ways to pay for these programming, because it does pay off in dividends. And really kind of that is my main message here in regards to my presentation today is ultimately who is paying for this failure, who is paying for our inability to make the changes. It is the local taxpayer, and it is those persons with severe mental illness and addiction that end up paying the price for what we have not been able to do. Those are my slides today. I hope this gives you kind of a perspective in regards to what's going on in communities across the country. And I guess we're going to take questions later on.
Commissioner, you're on mute.
Can you hear me now?
Yes, yes.
Okay, I don't know how I keep getting put on mute, but thank you very much for that helpful presentation. I mean, obviously, this is a cost shifting problem, and it shifts the cost down to the local counties and their detention centers. Our next speaker for today is Sheriff Jerry Clayton of Washtenaw County, Michigan, and we are very grateful to have you on today. I had the pleasure of serving with Sheriff Clayton on the NACo National Sheriff's Association Task Force on the Medicaid inmate exclusion policy, where we work together as local governments, stakeholders to organize an advocacy effort on this important issue. Sheriff Clayton is a 30-year plus public safety service professional, currently serving in his 4th term as sheriff of Washtenaw County. Sheriff Clayton leads an organization of approximately 420 staff, serving a population of over 358,000, covering a 720-mile geographical area. During his career with the sheriff's office, Jerry served as a frontline corrections officer, a deputy sheriff, and command officer. He was also appointed to serve as the corrections commander, police service commander, and SWAT team commander during his tenure. So you've done it all. Sheriff, the floor is yours.
Thank you. I really appreciate the opportunity to share a few thoughts, and I really appreciate the continued effort and work on this issue. Obviously, as we've heard to this point, it has budgetary implications, policy implications, but probably the most important thing is it has implications on people. Thanks again, Helen, for just sharing a little bit about me, so I don't have to go into any of that. Washtenaw County in Michigan would be seen as a mid-sized county, a mid-sized sheriff's office, full service sheriff's office. So what I'm going to talk about is probably pretty consistent with what a lot of you as county officials are experiencing and what a lot of my colleagues in the sheriff profession is experiencing. So one of the things we talk a lot about is not the sheriff's jail. It's the people's jail. It's the board's jail. It's all of our jail. And, the exclusion policy has a direct impact on the sheriff's office, the jail, and the larger, county general fund. Wellness costs for us, when talking about the physical health, behavioral health, it's approximately $3 million on an annual basis. That's out of a total of a $60 million budget that we have, and approximately 20 million of that is corrections. So it's a significant piece of the overall budget. And we've tried to focus in that area. In the last 5 years, we really thought about the behavioral health. So I want to give you just a little bit of stats and a little bit of a snapshot of Washtenaw County and some of our data, because I believe it's going to be the same as what we're going to see across the country. And then maybe broaden that out a little bit to talk about the impact of this policy on our ability to help position people to return back to the community in a successful manner. In 2018, we passed the Public Safety Mental Health Millage. And I mentioned that because during that time, we formed a diversion council and a data committee, and they did the hard work of sort of integrating or merging our jail data with our behavioral health data. I must mention that our mental health services are provided by Washington County Community Mental Health. There's been a strong partner. So a lot of the work is, if we've had any success, it's because of that partnership. So a little bit about the data. So we're trying to answer some very specific questions, especially as it relates to behavioral health. The rate of population people with behavioral health in our jail, and has that grown or has that reduced over the years? The time frame, I'm gonna give you a snapshot from 15 to 17, and we have a new snapshot coming up, but I want to give you data that was solid. The other question, how long are they staying in jail? How likely are they to return? All the things that we know are important. So here's some of our data. What we saw over a 3-year period is that we had an increase in the population of those individuals that were known by a mental health provider, which means they were clients outside or they'd had interaction and they received services. So it had grown from 24% to 29%. And as we start to compare that population in our jail versus the population in our jail with no known behavioral health disorders, here's some of the things that we found that were really disturbing and reinforced our need to focus our efforts. The average length of stay for a person with behavioral health disorder, known as CMH, was 27 days. If you did not fit that category, it was 11. The recidivism rate, the return to jail rate for that population was 58%. For the regular general population was 29%. And we saw that the female population was more likely to be known or admitted to CMH with behavioral health challenge versus male. We also identified that Black folks incarcerated in jail that are African-American and Black were less likely to be known, so they weren't getting connected and having treatment. And then when they got into the jail, their numbers started to increase. And our younger population, under 30, were less likely to be connected to our mental health services. So it started to give us an idea where we need to focus our attention. On the policing side, we know our data showed us that on average, our deputies come in contact with at least 2 people in some kind of mental health crisis per day. And our records also show about 60% of our population of those individuals on some kind of psychotropic medication. I'll come back to the youth, but I want to answer, questions that I know we always get. So it says, what's the percentage of the population requiring re-enrollment? Now I'm going to go right to MIEP. So for those individuals that come into our jail, 70% of the people in our jail have been incarcerated for 30 days or more. So we know a large percentage of our population are getting taken off the rolls and have to be readmitted. And we know the impact of that. So not only readmitted for their Medicaid, but all of their health and human services benefits. We also know that 77% of our population is pretrial status. So these are folks that haven't been convicted of anything, as we all know, and they end up coming into the jail, they stay beyond 30 days and they get taken off of the rolls. The impact is significant for us. So for us in the jail, we have to be really mindful and coordinate our management of that population to reconnect them to those services and better position them to have some continuity of services when they leave the jail going back into the community. So some examples of the things that we have to think about and coordinate. So as I said before, mental health, community mental health is our mental health provider. We work with them as part of our discharge planning team to make sure that we coordinate whatever behavioral health services they get in jail and connecting those to the community. That becomes a larger challenge if it's not a Washington or county specific service, if they have some other service that they have within the community, because now they've been taken off the rolls and we got to get them reactivated. And oftentimes they can't get those services until those benefits have been reactivated. Same thing with physical health issues, trying to reconnect them to whatever services they're going to get back into the community. As you know, the first question they're being asked is, what's your insurance? Do you have Medicaid? And the fact that they don't actually, and we've had many of our folks are incarcerated, get really stressed and really scared when they find out that their services have been disconnected and it's going to take some time for those to get reconnected. And what we're seeing, especially before we started implementing some of our programs, is that was a big contributor to the recidivism rate. Folks were coming into the jail, they were getting stabilized, they were receiving services, and because they did not have their Medicaid, they go back into the community, those services would get disconnected, and it would impact them from a behavioral standpoint, and the same behaviors that landed them into the jail the first time lands them into the jail the second time. For us now, we have implemented a diversion program where we're still running into some of those folks that now been disconnected from their services, but because we're running into them and our deputies have the latitude to not take them to jail, we're connecting them to services that they can get from the county. At the end of the day, this still ends up being on the county dime. It's the county that's paying for it. It's the taxpayers that's paying for it. And I think we pay for it 3 times. We're paying for it when they end up in the jail. We're paying for a lot of those services when they can't get connected back into the community. And if we fail to make that connection, we're paying for it possibly a 3rd time if their behavior leads them to a situation where they're reoffending and they're coming back into the jail. So for us, it is really important that we find some kind of way to provide that continuity of services and start to reduce the financial impact that it has on the county. We're paying one way or the other. If we're not paying it from a sheriff's office jail budget, we're paying it from the regular county general fund, and we're paying more money because we're not doing it in a strategic manner. I believe I've covered most of what I was asked to cover. I will just pause now and wait for questions.
It's wonderful, wonderful presentation, and thank you for being such a champion on this issue. Now to round out our discussion, we're going to hear from our NACo Legislative Director, Blair Bryant, who will provide an overview of NACo's advocacy resources. So Blair, the floor is yours.
Thanks so much, Chair Stone, and good afternoon to all of our webinar participants. And I just want to give a special thank you to all of our speakers today. They've been great in terms of outlining why this issue is so important to all of our memberships, which include NACBID, NACo, and the National Sheriff's Association. So thank you to all of our speakers. So in the long journey that we hope ultimately ends with the amendment of the Medicaid inmate exclusion policy for pretrial detainees, there are many things that we can be doing to work towards this ultimate goal. So I've placed on the screen before you kind of a diagram of what I call our all gears in motion strategy. So these gears represent things that we can be doing simultaneously to advocate for the amendment of the inmate exclusion policy. So our first opportunity is the package that Rodney, who talked at the beginning of the call, mentioned and provided details on, in which policy writers can be attached to the omnibus that's coming at the end of the year. So as mentioned, this is our opportunity to present our policy asks in a critical window of time in which Congress will be finalizing legislation before the end of the year. So what you see on your screen is a diagram of the all gears in motion, with that first gear being the MIEP provision for juveniles. One of the gears in this specific diagram is the Senate Finance Committee's discussion draft of their youth mental health provisions, which we hope to see attached to the end of the year omnibus. This provision, the juvenile provision, would amend the Medicaid inmate exclusion policy for juveniles that are in pretrial status. This provision was included as a modified version of the bipartisan Due Process Continuity of Care Act, or S-2697, which restores access to Medicaid benefits for all pretrial detainees. So this is a modified version of that bill. We still want to see the full passage of that bill, which was introduced by Senator Cassidy earlier this year. But we do also hope to encourage the Senate to continue their work on this modified version for youth in particular. Our speakers today have highlighted the potential impact of this provision, given the number of juveniles who are entering the justice system and the burden of mental illness in this justice-involved population. We see this provision as an important first step towards our goal, in that it chips away at this unfair policy. And we're urging Congress to repeal the MIEP for juveniles pending disposition, while we also continue to put other policy gears in motion with advocacy. So alongside this moving gear, we also want to be advocating for additional policy related to the MIEP that has not been promised in a potential end of year package. These policies include, first, the Medicaid Reentry Act, which you see on your screen is HR 955 and S285. And what the Medicaid Reentry Act would do is it will grant new flexibility to restart benefits for Medicaid eligible incarcerated individuals 30 days prior to their release. It will make it easier for states and counties to coordinate effective addiction treatment and other health services, while also allowing for a warm handoff to community care and reduce risk of overdose deaths post-release, as well as ensuring smooth transition back to Medicaid for those who are already eligible for Medicaid coverage. The other policy that we can be putting in motion is the Equity and Pretrial Coverage Act, or S3050. And this bill would allow otherwise eligible individuals who are in custody pending disposition of charges to receive healthcare benefits through all of the federal health programs, which include Medicaid, Medicare, and the Children's Health Insurance Program, as well as the Department of Veterans Affairs Health. So our last gear, in addition to the ongoing policy gears and then the provision that we're going to see in the Senate mental health package, is a smaller lift, such as study language that would allow for data that we need to make the argument for further changes to MIEP. This is something that we can advocate to be added to either an end of year package or any moving legislative vehicle that we see in this Congress or perhaps in next Congress. It's essentially another tool in our toolbox that will allow us to continue to keep the pulse of motion towards our ultimate goal of MIEP repeal for pretrial detainees. So that's our all gears in motion strategy. And with this in mind, on our next slide, I want to go over some resources from NACo that will arm you all with the information and tools that you need to go out and be effective advocates on behalf of MIEP. So with that, I'm pleased to announce that we have created a modified version of our MIEP task force homepage, and we've now called it the MIEP Advocacy Toolkit. It has the same amount of information that we've included in our task force page, which includes talking points, background information, and of course, a link to our task force report, which includes important data about the importance of revising the MIEP. So that was a result of our year-long task force and study in which Commissioner Helen Stone took part of, as well as Sheriff Clayton. So new to this advocacy toolkit is a sample letter that I will place in the chat, which you can be using now to modify coming from your own county in your own voice and send to your congressional representatives, talking about the importance of the amendment of MIEP and calling for its passage in any legislative package that we see towards the end of the year. Again, we're eyeing that critical time in which Congress is making their final policy decisions in December. We missed the opportunity to have these policies attached to the continuing resolution. So this is our opportunity to really push this in the last few days of the 117th Congress. So on our toolkit, you'll see a link to that letter. I'm going to also link it in the chat here, and I'll also put the link that you see here on the page, on the slide in the chat. Coming soon to the toolkit, we'll have a letter to the editor that you can, again, modify and be sending out to your local media sources, as well as to other national media sources as well. We'll also have some sample social media posts, including tweets and Facebook posts that you can be using to, again, keep the pulse of advocacy on this issue. So with that, I will put the toolkit link and our letter in the chat, and I will pass it back to Commissioner Stone for questions.
Thank you, Blair. So now we are opening up the floor for any questions. I don't know if you all have put them in the chat, but we want to make sure that we address your questions of our speakers so that we can answer them in the order in which they are received. Are there any questions at this time?
So, Commissioner, we do have one question in the queue, And that question is, should we still be getting co-sponsors for HR 955 and S 285? And the answer is absolutely. We want to be building a drumbeat of support for both of these bills. But I think the most important thing is reaching out to relevant committee staff as well as your representatives, asking that they would support this bill, not only as a co-sponsor, but as an attachment to any sort of end of year package. So again, we have a very distinct ask, and that's that MIEP in any form gets included in an end of year package. So while it's important to get co-sponsors, we want to make sure that those co-sponsors will also be advocates for its inclusion in a package.
Yes, and this should be really a nonpartisan issue. This is simply, as I stated earlier, I mean, it's nothing but cost shifting from the federal government down to the local taxpayers. So, this is something that we all need to push for, and it's hard. I mean, they don't want to spend the money. So, but I cannot stress to you how important this is. And also, Blair, I'm just going to make a comment that, because I think we have the time, of something that was brought up, I believe, during the task force discussions, and certainly is relevant from my experience. And that is, it is a little bit unfair because people that can actually bond out, have the money to bond out, may not lose their benefits because they're not sitting there for 30 days. So this really affects people of lower income and probably some of the people that need it the most. So I cannot stress to you enough for those of you that are listening, to look at this toolkit, review it, discuss it with your fellow commissioners, and meet with your Congress representatives, and whether it's Senate or House, and try to help us here.
Thanks so much for that last part, Commissioner. There was a question put in the queue about summarizing steps to be taken at the county level, and you just went over all of them. So thank you so much for that. We do have.
Well, I will take it one step further. Our county and Blair, I think I mentioned this to you before, in Chatham County, we actually passed a resolution on our commission urging our Congress representatives to support this. So that's, maybe another measure that could be used.
Absolutely. We have one hand up, and I will need some, Bea Thayer. So if you're able to unmute, then you can please ask your question.
Good morning. Thank you for all that great information. Can you repeat what the bill number was to receive Medicaid and all the benefits for pretrial detainees? You only put on the slide pretrial for juvenile or reinstating 30 days prior to release, but there was a S3050?
Yes, that's the exact number. S3050 is the Equity and Pretrial Health Coverage Act, and that will restore Medicare, Medicaid, Children's Health Insurance Program, and access to the Department of Veterans Affairs Health.
Thank you. And do you have a link to that? Because you provided the links to the other two bills.
Yes, I can have some NACo staff drop the link to that bill in the chat.
Fantastic. Thank you, everybody, so much.
And then I believe we have a question in the queue for Renee. And that question reads, in El Paso, how would Medicaid coverage of in-jail services help counties, since Texas has still not expanded Medicaid, which would cover many justice-involved individuals?
This is true that Texas is not a Medicaid expansion state. However, even without that additional coverage, we have many individuals that we know would qualify even under the existing restrictions. So I think it would benefit every state, whether you are a Medicaid expansion state or not.
Correct.
And of course, in the area of children's care, that is not necessarily applicable, since the children's benefits in Medicaid are much more generous.
Thank you. Then we have one more question in the queue. Would this maintain Medicaid for only pretrial, and would it end once convicted and incarcerated in a county jail? And I'm going to ask for clarity on that question. Is this in reference to a specific bill? I'm going to do my best to answer because I don't know if the person who asked the question is still on. But the bills that I mentioned and the goal that NACo and the sheriffs are pushing are for pretrial detainee access to Medicaid as well as other federal health benefits. The burden on jails caused by pretrial detainees losing access to their federal health care benefits, not only in terms of fiscally, but also the burden on the community for discontinuity of care is really our primary focus. So we are not focused on repealing the inmate exclusion policy for the entirety of the jail populations, and obviously not for prisons, but just for jail pretrial detainees.
That's right. Blair, are there any other questions?
Not that I see in the chat. Someone asked if there's a sample resolution to submit to county commissioners. We put the sample template letter towards your federal representatives in the chat. And Commissioner, maybe you want to take that question about whether or not there's any resolutions that can be passed at the local level to prompt support from state and other levels of government.
Yes, I think that we took the template that you all had and conformed it to a local level. And I'll be happy, Blair, when actually our county offices are closed today because of the storm. And when everybody gets back on Monday, I'll be happy to see if our clerk can find a copy of that resolution. She should be able to, and get that to you, and then it can be distributed.
Awesome. Thank you.
Okay. Well, at this point, unless there are any other questions, we've come to the end of time. So I'm going to close this out with a couple of final remarks. First of all, I would really am grateful that you all joined in today, and I can't thank our speakers enough for the helpful information and for their insights. We got to work on this collectively as county governments, jails, and the behavioral health workforce to create a system that allows all individuals to receive continual care for their health and mental well-being through access to care, coverage, and resources. And I hope you all will join me in using the tools that we discussed today in this issue with your congressional representatives, and continue to work with our federal partners to strive towards the ultimate goal of repealing the Medicaid inmate exclusion policy for pretrial detainees. And I want to thank you one more time and wish you all a wonderful afternoon. I am elated here. It looks like the sun might be coming out. And so this has been a little bit stressful, but it's turned out to be great. So thank you all very much for participating today. Blair, thank you for putting it all together, and stay in touch and have a wonderful afternoon.